Thank you, Dr. Slavin. I'm deeply honored to serve as the chair of the AAMC Board of Directors, and I'm also more than a little anxious about the next 20 minutes. From the moment that Darrell asked me to serve as the chair-elect almost 2.5 years ago, frankly, I've been sweating this talk. So I thought I would enlist some expert assistance to introduce my subject.
Thank you all for coming to Tribal Council. Any history of bone cancer, osteogenesis imperfecta, or multiple myeloma?
Could be a blood issue. We should run a CBC and a D-dimer.
And get an MRI.
MRI or a PET scan?
If the problem's vascular, he's better off.
Sorry. Thanks for playing. Patient's dead. You killed him.
You think that's gonna stop me from telling him?
If you do, I'll get you thrown out of medical school.
I haven't done anything that would merit that.
I know, but unlike you, I'm willing to lie.
I lead, you draft. I move, you move.
When I move, you move. You're interns, grunts, nobodies, bottom of the surgical food chain. You run labs, write orders, work every second night until you drop and don't complain.
In a few hours, you people are taking a test that will determine the course of your entire medical careers. But are you studying for this test? No, you're not. Are you helping out in the ER? You are most certainly not. Are you getting the hell out of here before I throw you out? I think you are.
Pagers, nurses will page you. You'll answer every page at a run.
These are your beepers. From now on, they control your entire life. Okay, thanks. Move it.
Despite the fact that when you wake up tomorrow morning you will be a resident, you'll still be the same excitable little girl that you are right now. The only difference will be that some sorry new intern will probably mistake you for somebody who actually knows something.
If you were in my way, I'd throw you off this ledge right now. We're out here alone. No one would ever know.
I have to... things.
Interns are fun.
Rude, disruptive, belittling behavior can be funny when it happens to somebody else on TV. In real life, not so much. Let me tell you three real-life, not-so-funny stories. A third-year medical student begins her surgery clerkship. She's heard how difficult some of the attending surgeons can be, but she thinks she's prepared. When she enthusiastically expresses her interest in family medicine, one of the surgery attendings sharply replies, "Family medicine isn't real medicine. If you end up doing that, you won't be a real doctor." A hospital administrator received a letter from a patient who had been in the hospital for just 2 days. He wrote, "The healthcare professionals as a whole are impersonal. The doctors barely talk to us. The residents are ill-prepared and do not collaborate enough with the attending physician. Many nurses and other professionals freely share patient information in the hallways. If things continue as they have, then we will probably never use your hospital again for anything." A faculty member interviewed medical students, residents, anesthesiologists, and surgical nurses to collect data for a study of disruptive behavior by surgeons. Here's one interviewee's description of a disturbing incident. He was angry, yelling at the nurse across the desk. And then he came around the desk and actually pinned her up against the wall and had his hand on her throat while saying, "You can't take my room away from me." People had to pull him off. Another interviewee said, "The institution gives them the signal that they bring in a lot of money and they can do whatever they like." And so they do. The institution turns its head because to fire a surgeon, well, you're probably talking tens of millions of dollars. I'm sad to say that these stories are from my institution. But I'm certain that you all have your own stories. Most of you have seen demeaning, disrespectful, and disruptive behavior in your institution. Many of you have experienced it. And some of you have been responsible for it. Now, you may argue that the offenders are a small minority. Individually, we are good doctors, nurses, physician's assistants, residents, and people. After all, we're healthcare professionals. It's just a few bad actors who give us all a bad name, right? But when you look at the numbers, another story unfolds. The American College of Physician Executives recently conducted a survey to quantify disruptive physician behavior. 840 physicians responded, and of those, 70% said that they observe disruptive physician behavior every month. And 11% said that they see their colleagues behaving badly every single day. Just think about that. And then when the survey asked if they themselves had exhibited disruptive behavior sometime in their career, about 25% admitted that they had. And you've got to wonder whether maybe there's a little bit of underreporting on a question like that. In another study using a meta-analysis of the literature, Phineas et al. Found that nearly 60% of medical trainees had experienced at least one form of harassment or discrimination during their training. 60%. These numbers corroborate what I believe to be true, that disrespect is more systemic than it is isolated. Unfortunately, it's part of the culture of medicine, a culture that has existed for decades, if not centuries. Disrespect doesn't just manifest as egregious behavior like angry outbursts and verbal threats. It's embedded in how we practice medicine. It can be as subtle as referring to patients by their disease, the herniated disc in room 214, as self-centered as scheduling all your patients to show up for clinic at the same time and then making them wait, and as blatant as a surgeon refusing to take a mandated timeout in the operating room. For years, we've tolerated or ignored the problem, perhaps using a "that's just the way things are" attitude. Now, finally, there is growing recognition of disrespectful and disruptive behavior by physicians and efforts to deal with it. The AAMC deserves much of the credit for creating awareness and bringing the issue to the forefront. Last June, the board of directors unanimously endorsed a statement concerning mistreatment in the learning environment. A portion of that statement reads, "We affirm our commitment to shaping a culture of teaching and learning that is rooted in respect for all. Fostering resilience, excellence, compassion, and integrity allows us to create patient care, research, and learning environments that are built upon collaboration, mutual respect, and human dignity." I think all of us would agree with that statement, and we would all aspire to have those kinds of collaborative and supportive environments. Unfortunately, despite our best intentions and admirable efforts at many institutions, bad behaviors persist, and they seem to resist our best efforts to change them. Take, for example, the David Geffen School of Medicine at UCLA, which in 1995, long before the issue was on many schools' radar, did four things over time. They instituted policies, they created reporting mechanisms, they provided resources, and they began educating faculty and residents about student mistreatment. In addition, they surveyed the students every year to determine the frequency of mistreatment. As recently reported by Freed and colleagues, the overall incidence of mistreatment during clinical clerkships did fall by about 25% during the first 2 years of the program. But then for the next 8 years, the incidence remained unchanged at about 57%. Similarly unimpressive is the progress we've made around the country. Mavis et al. Studied responses to the graduation questionnaire between 2000 and 2012 and found there was essentially no change in the percentage of students reporting incidents of personal mistreatment. Regrettably, only a third of students who experienced mistreatment even reported the incidents, also a number that had not changed over that period of time. So why is it so hard to eliminate these behaviors? I believe it's because programs that are focused on student mistreatment or the disruptive physician are directed at treating the symptom and not the disease. Bad behavior is the symptom. A culture of disrespect is the disease. And culture is very hard to change, especially a dysfunctional culture that resists change, as Leap et al. Concluded. In their words, central to this culture is a physician ethos that favors individual privilege and autonomy, values that can lead to disrespectful behavior. Well, I don't know about you, but many physicians went into medicine in the first place because of that privilege and autonomy. Is it any wonder, then, that it's so hard to change? Okay, I know we all have a lot on our plates. These are certainly challenging times in academic medicine. Change is happening at a relentless pace, whether we like it or not, and it seems almost impossible to keep up. Just glancing at the agenda for this meeting is a quick outline of the things that we need to fix. While we worry about new payment models, constrained NIH funding, ensuring competence of learners across the continuum, and our very survival, the treatment of medical students or dealing with a tightly wound physician can sometimes seem like the least of our worries. But I agree with Lucian Leap and others who argue that it's the dysfunctional culture, not a lack of know-how or resources, that leads to underperformance in every corner of our organization. Our culture of disrespect creates obstacles to patient safety and to working effectively in teams. It produces hostile work environments, dissatisfied patients, and an increase in malpractice claims. For medical students, what they see and experience in our organizations can cause humiliation, shame, self-doubt, and low self-esteem. Worst of all, students often emulate the bad behaviors of their faculty and resident role models, and thus the cycle goes on and on. My point is that recognizing and addressing this culture of disrespect is not simply the least of our worries. It is foundational to our survival. It can't be on the back burner. It's the burning platform. We need to take on and fix our culture so we can successfully deal with all of our other challenges. Let's stop treating just the symptoms. Let's find a cure for the disease. Let's stop being defeatist about changing a deeply entrenched culture and begin to believe that change is not only vital, it is possible. So what have I learned from this experience? Well, I've learned that changing culture of our organizations is not for the faint of heart. It takes courage. It takes the courage of leaders who must be persistent and consistent in pushing towards their goals. It takes the courage of faculty and staff to work together to find solutions to seemingly insolvable problems. It takes the courage of students and staff to identify people who are not on board with the program and the courage to move them out. And it takes courage to speak up because, as the philosopher Plato said, I shall assume that your silence gives consent. Along with courage, we also must create systems and establish policies to engage and motivate change in our organizations. These include a zero-tolerance policy for both mistreatment and for not reporting failures, a safe and non-judgmental reporting environment, and an expectation of personal accountability. We need to identify or create meaningful metrics to monitor our progress, and transparency to celebrate our successes and to challenge the laggards. And if we expect our providers to respect their support staffs, students, and patients, we need to design systems that fundamentally respect them. A tall order, but I believe it can be done. Learn, serve, lead. That's the theme of this meeting. So I ask you, how many of you can learn while being bullied? Who wants to serve their patients in a hostile and disrespectful system? Certainly nobody in this room. And who among you has the courage to take the lead in changing our culture? I believe there are many among you here today who are not only willing, but who can make a big difference. So I call on you to begin the work of breaking up this age-old and useless cycle. Individually and collectively, we need to act now. It's a good business decision. It's a good people decision. Moreover, it's what our patients expect and deserve. It's what our learners expect and deserve. And it creates the kind of environment that we all want to work in. And working together, I believe we can achieve it. I wish you success in your journey, and thank you very much.